Hello everyone, so today we're going to be doing COPD, that's chronic obstructive pulmonary disease. Let's get into it. This is basically a chronic inflammatory lung disease that causes obstructive airflow from the lungs. So basically, when we think of COPD, we want to think of a persistent cough. That's always going to be the answer on the test question. Persistent cough. Why? I'll show you why. So there are three subgroups: asthma, emphysema, and chronic bronchitis. Now, asthma is a condition where the airways become inflamed, narrow, and swell, producing extra mucus, which makes it difficult to breathe. As you can see in that video, there's a lot of shortness of breath, wheezing, chest tightness, and coughing. Wheezing is going to be your main hint. So this asthma, of course, everyone wheezes, right? But like asthma, there's wheezing. There's that high-pitched sound. And basically, as you saw in the video, she has inhalers, which we'll get more into. Emphysema. This is a condition where the alveoli, the air sacs at the end of the smallest air passages, which is the bronchioles of the lungs, they get destroyed and this is because they either smoked or they damaged the lungs because of the fumes and all of the air pollutants. Oh dear. So as you can see in that video, there's some shortness of breath. That chronic cough, I bet you she has been coughing for months and the cough had never been, it's still there. Wheezing, fatigue, frequent respiratory infections, cyanosis. So there is a persistent cough, just like chronic bronchitis. This involves inflammation of the lining of the bronchial tubes, which carry air and from the air sacs, alveoli of the lungs, and this is characterized by daily cough and mucus symptom production. So this symptom is going to be your key identifiable pointer for chronic bronchitis.
What my neighbors hear every morning at 5 a.m.
I mean, and whenever you hear inflammation or itis, inflammation, so on test questions, just keep in mind that this is more of an inflammation. It's not emphysema. However, persistent cough, as you can see in the video, mucus production, shortness of breath, wheezing, chest discomfort, that daily cough, that daily symptom production. And as you can see, persistent cough on emphysema and chronic bronchitis is just like key for COPD. Just never forget that. Causes, as we kind of saw, there's smoking as the primary cause. I mean, just like always, fake smoking on the test question. Long-term exposure to irritating gases, air pollutants, and these are genetic factors as well. Risk factors, for those patients who are 40 and older, you are at higher risk. History of childhood respiratory infections. So if you are if you know you've had a little lung infection or even just a cough that wouldn't go away as a child, you are at a higher risk. And of course, if you're exposed to a lot of dust, chemicals, and fumes at your work, smoking, or worse, secondhand smoking. Like if someone smokes beside you on the highway, try to move away, because I mean, if they can't move away, you move away. That's always something I abide by. Anyways, vitals and effects on spirometry. So spirometry is a common test used to diagnose COPD. It measures how much air you can breathe in and out, how quickly you can blow air out. So the metrics include FEV1, forced expiratory volume in 1 second. These lower values indicate more severe obstruction. Now, when it comes to FVC, forced vital capacity, this is the total amount of air exhaled during the FEV test. Now, this ratio is a big one because the FEV/FVC ratio is used to determine the presence of obstructive lung disease. So when we look at this graph here, we can see that there are the healthy subjects who have more breathing time, and then we can see that the COPD patients have less breathing rest time. So as you can see there, the breathing frequency at rest is 12 to 15 minutes. You can see where it says the mild COPD, how very short, and then the severe COPD. It doesn't even reach the inspiratory residual volume. But yeah, this is interesting to look at. That was approximately 4 seconds, inspiration, expiration. And it's unfortunate.
Patient just did a pulmonary function test, and this is his forced vital capacity. The forced vital capacity represents how much you can breathe out in total, and this is 37.8%. Now, in a spirometry, we can call this low because of restriction or low because of obstruction. Now, I know this patient is obstructed mostly because I'm looking at the flow volume loop and I'm looking at the FEV1. This is severely decreased because the patient cannot exhale properly, and this is what we call air trapping. Now, somebody might look at this, a novel person might look at this and say, no, doc, this is restriction. Well, it is possible that it is restriction, but again, when you look at the flow volume loop, you can see this concavity right here, and then you see that everything is shifted to the left. You know that this patient is very severely obstructed. That's why when I look at the GOLD criteria, I really only focus on the FEV1, not the FEV1 over FVC ratio, because it can really mislead you. So an FEV1 less than 30% is very severe, and FEV1 greater than 30% is severe obstruction. So what we have done in our lab is we're putting the plethysmography and the spirometry over each other to kind of prove this point. So what you can see here, we look at the total lung capacity and we look at the residual volume, and then we look at the residual volume over the total lung capacity. Here you can see the total lung capacity is 136% predicted. So the patient is not restricted. The lung capacity is very, very high. But look at the residual volume. The patient's residual volume, what is left, is 332% of what was predicted. So essentially, I say the patient is expected to leave about 2.36 liters in his chest, and he's leaving 7.84 liters in his chest, which is 300% predicted. Now, we look at this thing. This is the RV over TLC. RV over TLC is 224% predicted, and anything above 150 is considered air trapping. So clearly the patient is trapping air due to severe COPD. Severe COPD because the FEV1 is greater than 30%. If it was less than 30%, it would be very severe COPD.
The medications used. So we've seen bronchodilators. These relax the muscles around the airway. Albuterol is a good example. Inhaled corticosteroids. So these reduce inflammation. Combination inhalers. So these inhalers are combined with bronchodilators and steroids. Corticosteroids. Antibiotics are used for treating infections. So what you're going to see is that these come in pills, and then if you have had like that cough that won't go away, then you see that people taking these antibiotics. And then there is the phosphodiesterase 4 inhibitors. These reduce inflammation and relax the airways. So taking a look on other parts of rehabilitation, as physical therapists, we include our exercise training, advise them on nutrition, especially on smoking and their environment, and educate them on any other aspect, depending on what subgroup they may likely be having. Exercise training, because it improves cardiovascular fitness and muscle strength. Resistance training, because it strengthens muscles, especially those used for breathing. So a lot of your intercostals for inhalation, the core is a massive one, so we can help you with that. However, breathing exercises, when it comes to that, we have pursed lip breathing. So this is the main one that you're going to hear for COPD. This helps release trapped air from the lungs and improves breathing efficiency. Diaphragmatic breathing. This strengthens the diaphragm and improves breathing control.
Avoid breathing only into the belly. I see this mistake a lot with my patients. You also want to avoid breathing only with the chest. See how my ribs flare with every breath? To perform a proper breath, place both hands on the rib cage. Inhale through the nose, allowing the ribs to expand 360 degrees. The belly and chest will rise slightly. Exhale and release all tension.
Deep breathing prevents air from getting trapped in the lungs, and huff cough helps clear mucus from the lungs. At the end of the day, guys, it is important to work with your healthcare professionals and make sure that you are improving your symptoms, because with this it does progress over time. So you do want to manage the symptoms. You do want to live a very comfortable life, and I believe you can do it.